Hello, everyone. I'm Suzanne Toppy, Editorial Director at Springer Publishing Company. Welcome to today's webinar, Rethinking Pathophysiology to Empower Students for Lifelong Success. Our speaker today is Nancy Tax, editor of our just published textbook, Advanced Physiology and Pathophysiology, Essentials for Clinical Practice. At the end of this presentation, you will have the opportunity to participate in a survey and request a desk copy of this new textbook for your review. Nancy Tax is Associate Professor Emerita from the University of Pennsylvania School of Nursing. She is a master's prepared nurse and holds her doctoral degree in physiology from Loyola University of Chicago Graduate School at the Stritch School of Medicine. Dr. Tax has been teaching pathophysiology at the graduate level for over 25 years at various institutions, including the University of Medicine and Dentistry of New Jersey, the University of Pennsylvania School of Nursing, and the University of Southern California. We are thrilled to have Dr. Tax with us today to talk to you about her personal approach to teaching graduate-level pathophysiology and how you can empower your students to become lifelong learners by applying what they learn about pathophysiology to their clinical practice throughout their careers. Dr. Tax will be happy to answer any questions you have at the end of this presentation, but you can submit your questions at any time by clicking on the Q&A button at the bottom of your screen. Please welcome Dr. Nancy Tax.
Good afternoon, everyone. It's a pleasure to welcome you to this webinar. I'm going to give you a brief overview of what the webinar covers. We'll be introducing the editorial team, talking about the challenges that we all face in teaching pathophysiology, and presenting to you a different way to think about teaching pathophysiology that empowers your students. I'll give an example describing the approach that the textbook takes to the teaching of the physiology and pathophysiology of the lung, the demonstration of teaching from principles to applications, and making some suggestions for optimizing pathophysiology teaching for your program. But first, I'd like to begin with a poll, and I would like to ask Erica to open up that poll. So if you see the poll questions, if you can just click yes or no answers, or in the last case, answer the multiple choice question. And I've asked Erica, when responses look as if they're slowing down, if she can then close the poll and demonstrate the answers or share the answers. Okay, so this is good. Have you taken an advanced pathophysiology course within the past 10 years? 42% have, and 58% have not. When you took your course, did you have a positive experience? 72% said yes, and 28% said no. And that is just so illuminating, because I think what we all want is for our students to have a good experience in this pathophysiology course. And then the student audience, 59% primary care and P, 23% acute care, physician assistant 10%, and other 39%. Okay, thank you so much for giving that information. I appreciate you sharing that. And now we'll go back to the main webinar PowerPoint. Erica, are you able to close that window, or I can close it? Okay, so those are our questions. Okay, so when I was in a undergraduate nursing program, physiology was my favorite subject. And again, when I went to grad school, I particularly am fond of this quote from Arthur Guyton: "Physiology is indeed an explanation of life. What other subject matter is more fascinating, more exciting, more beautiful than the subject of life?" So I was delighted to be asked by Springer Publishing to pull together the team of people who would produce this textbook to fit their new 3Ps series, and specifically design it for future healthcare providers who are going to be diagnosing, managing, and prescribing conditions. An overview of our editorial team. Again, Suzanne introduced my credentials, and we recruited Linda Herman from NYU, who is our gerontology expert. She has her doctoral education and bachelor's and master's from University of Pennsylvania, and at Penn, she was mentored by the very, very eminent gerontology nurse practitioner and clinician Neville Strumpf. And Linda has expertise in teaching pathophysiology and also courses on aging at the graduate level. Randy Johnson is on faculty at University of Tennessee Health Science Center and has taught pathophysiology in both undergraduate and graduate programs and has served as a pediatric critical care nurse practitioner. Linda actually is on the call today, so if you had any specific questions about gerontology content of the book, she would also be able to address those. And so between the three of us, we recruited a tremendous interdisciplinary team of authors and reviewers from basic scientists, RNs, NPs, PAs, MDs, PharmDs, RDs, pediatric and geriatric experts across all different degree levels, but all of whom had extensive experience teaching, doing clinical practice, or both. So when I first started teaching pathophysiology at the graduate level, I had just completed my postdoctoral training in neuroendocrinology at UCSF. And I came to grips with certain challenges in working with the group of students I had. First of all, there was tremendous variability in student readiness for graduate level sciences. The extent to which students had recall of chemistry, biochemistry, genetics, cell biology was very variable. And the degree to which they had retained many of the undergraduate physiology concepts really was very variable. So I had to come to grips with that. When I got my PhD in physiology, I had an organ systems medical physiology course that covered heart, circulation, lungs, kidneys, GI tract, endocrinology, and then there was a separate medical neuroscience course at the same time. But when I came to teaching this advanced pathophysiology course, I found that it also had to cover hematology, immunology, and infectious diseases and things that had been outside of the traditional medical physiology course. So there was so much content to cover, it seemed very overwhelming to me. Then the next thing is recognizing that the physiology and the pathophysiology of the body changes tremendously from embryonic to fetal development. So all of prenatal development plus infancy, childhood, adolescence, adulthood, and on into the changes that come in older adults. So trying to capture appropriate information about the lifespan changes was an additional time that had to be allocated. And finally, because this course came very early in the curriculum, it was taught concurrently with the advanced physical assessment class, but it was really the prerequisite for the courses on differential diagnosis, on management, and on pharmacology. And so to try to provide the relevant foundation for those courses that were to follow seemed like it was a very, very daunting task. And I was so afraid that my students would look like this, that they would be so overwhelmed, not just with the reading for my course, but all of their other courses, as well as juggling life as people who were working, raising families. I thought, I have to follow the precept of a mid-20th century architect, Mies van der Rohe, who coined the term, less is more. So as I was developing my first semester course in pathophysiology, I was aware, and I continue to be aware, of the trends in pathophysiology teaching. There's a greater focus on active learning, on case studies and practical applications. Courses are moving online with a variety of different approaches, including asynchronous content and synchronous content. And there are many rapidly evolving areas of science that are going to impact clinical practice for the future, in particular, genetics and immunology and neurobiology. So all of these pieces I am trying to build on as I'm building my very first course. And then we always have to name our course goals and objectives. What are the takeaways that we want our students to have from the pathophysiology course? We want them prepared to move into differential diagnosis and clinical reasoning. We want them to understand the pathophysiological and physiological basis of diagnostic tests, the CBCs, the clotting studies, the meaning of bilirubin, the meaning of the complete metabolic panel. What are those tests and what are they telling us about our patients? We want them, even before they start pharmacology, to have some general ideas about drug classes, about pharmacokinetics, about drug mechanisms and pharmacodynamics. We want them, in the recognition that we cannot teach every single disease that they will ever encounter, we want to give them the vocabulary and the concepts so that they can look up any disease on UpToDate or Medscape as they move into their clinical coursework and encounter something new. They should be able to learn how to learn about diseases. And finally, and perhaps most importantly, we want the students to understand disease mechanisms to be able to effectively teach patients and encourage and guide those patients to do their own self-care, because the patients understand the disease process because they have been taught by the clinician. So the broader goals for students are that they will master the key physiological principles that will enable them to learn how to learn about new diseases and to build that strong foundation in physiology and pathophysiology to be equipped for success in pharmacology and the subsequent clinical courses. So the strategies I adopted to help achieve these student goals included focusing on the most used topics and principles and the most common disorders, and to try to do those in sufficient depth that the students really mastered the jargon and the concepts. And one way that I did that was to sequence the teaching of the principles of organ function, followed by the clinical applications immediately. So for example, we all really take for granted as you sit there, just take a deep breath in and then just let it slowly out. And then think about the numbers of thousands of branching airways getting narrower and narrower in your lungs, representing airway resistance. But we never think about airway resistance when we're just breathing smoothly and easily. But when we see a patient coming in the throes of an asthma attack, and they are having such a difficult time breathing, we know that airway resistance is greatly compromised. So if we hone in on that principle that normal lungs have low airway resistance, then we can talk about diseases in which that normal function is disrupted. And that helps to reinforce the original principle, as well as making it clear why the disease process makes such a difference to the patient's homeostasis. So that sequencing you'll see another example of in a minute. And finally, it's so important to cover these tough topics that are really shaping our care now more than ever: genetics, immunology, neurobiology, that are impacting the care that we give. So what's the bottom line here? What does rethinking pathophysiology really look like? So here's an example, again, from the physiology and the pathophysiology of the lung chapter. And the blue-gray boxes are showing an overview of lung structure and function, followed by, in the tan box, the application of that to the diseases cystic fibrosis and pleural effusion. And then we move on to the big biophysical concept of lung and chest wall compliance. And then we apply that to a disease of increased compliance, emphysema, where the lung gets weak and floppy, and it's hard to empty the air out because the lungs are too compliant and allow too much air in, and then have no recoil to remove the air passively. And compare and contrast that with pulmonary fibrosis, where there is tremendously decreased compliance of the lung, and the patients have a very difficult time on inspiration, bringing in enough air to meet their needs even at rest, and cannot carry out additional physical activity because they're so limited in bringing air in. Then we move to airway resistance and apply that to asthma and to chronic obstructive pulmonary disease. Move on to gas exchange, where we talk about the different mechanisms of impaired gas exchange. So the normal alveolar air capillary blood interface, and then how it gets damaged during disease processes, leading to ventilation perfusion mismatch and shunt and poor oxygenation of the blood. So we interlace the principles of organ function with the clinical applications. And that helps the students reinforce the principles as they will be applied to many other diseases. They're all acting as a dysregulation of those underlying principles. So again, continuing with this theme of building from one principle to many applications, I want to ask you to just think for a minute, what do these conditions have in common? Asthma, diabetic gastroparesis, premature labor, and septic shock. I'll give you a minute to give some thought to that. So one answer to this is that all of these are disorders of the smooth muscle of the body. So in asthma, you have excessive contraction of bronchial smooth muscle, leading to an increase of airway resistance. In diabetic gastroparesis, you have a diabetic autonomic neuropathy, meaning that you don't have good vagal innervation of the stomach, which decreases the activity of the gastric smooth muscle. The stomach stays relaxed instead of having regular contractions. In premature labor, you have increased activity of uterine smooth muscle. And in septic shock, you have too much relaxation or inadequate contraction of vascular smooth muscle. So the principle here, the central principle underlying these conditions, is an abnormality of the smooth muscle that makes up the blood vessel walls or that lines your hollow organs. So the book in chapter 4 introduces the principles of muscle contraction, of cardiac and skeletal and smooth muscle. So let's look at the cellular mechanisms of smooth muscle contraction. So what you see here is the thick filaments of myosin and the thin filaments of actin in blue. The myosin is in red, and it has those heads that reach out towards the actin but not quite touching it. And all muscle cells contract by allowing cross-bridge formation of the myosin heads with the actin filaments and then ratcheting along them to shorten the cell. But for smooth muscle cells, that mechanism contraction involves an increase in intracellular calcium, which binds to a protein called calmodulin, CAM, abbreviation here, and that activates a complex. The active calcium calmodulin complex turns on this enzyme, myosin light chain kinase, MLCK, which phosphorylates myosin and allows it to make the cross bridges with actin to cause smooth muscle contraction. So this calcium-mediated contraction mechanism is true across all of the smooth muscle of the body. Now, let's think about where that calcium will come from. Well, that will really depend on which cell type we're talking about. So here's another picture from the book. This is from the lung chapter, and this is a picture of a bronchial smooth muscle cell showing the regulation of its contraction. And here I've divided the mediators and mechanisms into those that are bronchoconstrictors and those that are bronchodilators. And so at the top of the cell, you see a picture of a muscarinic cholinergic receptor that can bind acetylcholine released by vagal nerve fibers and will link to a G protein coupled receptor to ultimately increase a second messenger, IP3, that increases intracellular calcium by releasing it from the sarcoplasmic reticulum. Similarly, the inflammatory mediator that's elevated in allergic asthma, a leukotriene molecule, can also bind to a G protein coupled receptor and activate intracellular calcium release. That leads to the cascade that we saw in the previous slide: calcium, calmodulin, myosin light chain kinase activation, and bronchoconstriction. At the same time, we know that those bronchial smooth muscle cells have beta-2 adrenergic receptors that link to a different G protein coupled receptor, turning on the production of intracellular cyclic AMP. And the cyclic AMP is a second messenger that inhibits myosin light chain kinase and causes bronchial smooth muscle relaxation. So I think of a slide like this as both a pathophysiology slide and also as a pharmacology commercial, because basically what the student is going to proceed to learn in pharmacology class is that the management of asthma will involve things that block acetylcholine action or leukotriene action on bronchial smooth muscle, but will be increasing or mimicking the beta adrenergic receptor activity of the bronchial smooth muscle. So revisiting the original question I had, what do these conditions have in common? All of the conditions that I mentioned relate to abnormalities of smooth muscle. And in each case, we can make a story for the students about how that will relate to the management of certain conditions. For example, premature labor can actually be treated with beta agonist terbutaline to relax the uterine smooth muscle. And septic shock can be treated, amongst other approaches, with vasopressors that increase vascular smooth muscle contraction. So we generalize from the principle that all of these structures have smooth muscle controlled by autonomic neurotransmitters and other mediators, and we point towards management approaches without getting into too much depth, because that's really for the pharmacology class and the later clinical courses. The foundational principles that the students would need to have to understand that discussion include the things that are covered in Chapter 4 on cell biology, about the mechanisms of smooth muscle contraction, actions of ion channels like calcium channels, receptors and second messengers, and then autonomic functions that work on the various organ systems to exert these homeostatic effects. So let's just revisit these challenges in teaching pathophysiology. We had the varied student readiness, and we have to think about how we can provide students with an opportunity to refresh some concepts that are foundational: chemistry, biochemistry, but we have a lot to cover in a one-semester course, and we have to focus on principles and main applications. We have to help students connect the dots to their eventual clinical practice, and we will have to bring in lifespan considerations. And biologically, we have to be thinking about, for example, when we think about the kidney, and the kidney is developing during embryonic prenatal development, by ages 36 to 40 weeks of gestation, you will have all the nephrons that you'll ever have in your lifetime, but you'll have fewer nephrons if you're actually born prematurely. And so you will be at risk of later life challenges and things that are nephrotoxins and any insults to the kidney. At the same time, as you age, you have a loss of nephrons, and after age 40, every decade you lose more nephrons. And so the older adult will have more challenges, and that will impact prescribing of anything that perhaps could be a nephrotoxic drug. So you have to have the basic principles of embryologic and fetal development and also the processes of aging that will then impact clinical practice throughout the lifespan. So in this book, we have the chapters 2 through 4 can provide sort of a refresher of basic sciences of chemistry, biochemistry, genetics, cell biology. Before delving into organ systems, you can require that as a self-study bridge course before the semester starts, or you can give it as a couple of lectures at the beginning of the course. This one semester course will focus on principles with major exemplars that are then reinforced by thought questions that encourage the students to reflect. Have I really understood this section of this chapter? We will have principles that underlie major laboratory tests and drug classes with case studies and bridges to clinical practice. And then each chapter of the organ systems will focus on the key issues for the pediatric and gerontological patients for each system and the most common disorders for each of those patient groups. So this is where we tried in this book to put the solutions into action in a way that will empower faculty to empower their students. We have chunked the content by headings, major headings within each chapter is going to be based on physiological principles of organization. It is a far shorter text than many that are available there, but it provides a very flexible foundation that you can adapt to the needs of your specific program. We have the bridge to clinical practice segments and focusing on cellular mechanisms. Both of those are designed to segue into the advanced assessment and the pharmacology and the clinical classes and provide robust resources for instructor and student support. Other features of the book are the multidisciplinary nature of the authorship. I was particularly pleased to see the number of folks we were able to recruit, Linda and Randy and I, to handle these different chapters from their own expertise. I was particularly motivated to have help from people who are PharmDs, particularly with the liver chapter. Rather than being treated as an accessory organ of digestion, the liver is a freestanding chapter. The most common cause of acute liver disease in this country is actually drug-induced liver injury. And so it was very important to me to recruit people who would talk about the role of the liver in pharmacokinetics. And it happens they also had expertise in conditions like hepatitis C, which is so common now and is now treatable. And so I feel that we really found the right people to fit the bill to write the chapters. It's richly illustrated with over 500 full color illustrations. And if your students are visual learners, if they can see the picture and really understand the picture, then they've gotten down to that real concept or real principle of how a system works. And that is good for all kinds of learners, because I find that if students can work together in study groups, the visual learners will sometimes be able to sketch things for those who would like to flesh things out with having a good text to read. We have comprehensive and yet concise pediatric and geriatric considerations for each chapter, the bridge to clinical practice, in order to save space and to help students organize their knowledge. We have many tables. We have thought questions so they can really do a knowledge check of whether they're getting it. Are they getting the main concept? And we have case studies with explanations. But the whole package is 840 pages and very readable 12-point font. I have noticed other texts actually have very small font that's very, very challenging for me to read at my age. Then instructor resources that help you fine-tune the material. The instructor manual for each chapter will have the summary and the outline. I have added a section called Connecting the Dots, which gives you tips for teaching each chapter. And then we have provided discussion questions, individual assignments, and group assignments. And I think these are really important, particularly if you're teaching in the online environment. I was fortunate to teach for the University of Southern California in the online environment. And we had asynchronous, the students had to watch each lecture chunk and answer multiple choice questions on each chunk. And then when they came to their small group online live sessions, we had additional group discussions that we could have for breakout rooms and use something along the lines of these discussion questions and group assignments, and then the groups could report back. But you could just as easily do that on a chat wall. If you have a chat wall for each organ system and have your groups wrestling with some of these questions, the discussion questions, individual assignments, and group assignments, the answers are provided in the instructor manual and not in the student resource manual. And so those are more for instructor use, whereas both the instructor manual and the student manual have the answers to the case studies and the thought questions. But you can continue to flesh those out during your face-to-face time, or have students arrange their own Zoom meetings and then report back answers to and their further thoughts about some of the case studies and thought questions. And then there are PowerPoint lectures for each chapter. There's an image bank, and there is also a test bank. I really, really hope you will keep in touch. This is a first edition, and so we really want information and feedback about what was helpful, what worked for you, what did you feel you needed extra support on. As the science evolves daily, we are learning more all the time. A static textbook cannot be the complete answer. We always have to keep things up to date ourselves as faculty, and then encourage our students to be getting ready for that lifelong learning. And so I've set up a Twitter account at Dr. Tax Patho. And so I will be posting there. I'll try for once or twice a week sharing. But you could have your students require them to follow the Twitter account, maybe submit their own tweets as part of a class assignment. And then I'm giving a plug to this at Tony Breu. He's one of the best of the online Twitter teachers of pathophysiology, and he has some fantastic complex case pathophysiology tutorials that I'm very admiring of his style. But then you have to engage your students to develop their own pathophysiology flowcharts, tweet articles that they find useful, and create new algorithms for learning some of the steps of pathophysiological processes. So I think that's the best way to really get the students to make the most of this course and engage in the material. There may be interest in creating a LinkedIn group for faculty who adopt the book, and I would be very, very open to that. I would be eager to see that type of a resource become available. So I've used up the time that I wished to use, and I really would like to open it to questions, and Suzanne will be moderating that portion of the session. Thank you so much for your attendance.
Nancy, we have a few questions. So here's the first. Are there any body systems or topics that are covered more in depth in your book? And then are there any that maybe aren't as in depth, and why would that be?
Yes, so I would say that I've given the most depth to the topics of immunology, liver, neurobiology, and the genetics. The genetics has its own chapter, but there's also embedded genetics disorders with a special icon across the organ systems chapters as well. And the choice that I did make when assembling the table of contents of the book, there is not a freestanding chapter on the skin. when I looked at the underlying principles of the vast majority of skin disorders. They were in two major groups. One is infectious disorders, and the other is immune-based disorders such as autoimmune disease and hypersensitivity. And so I took those common threads, and within the infectious disease chapter, it does discuss the dermatophytes, the fungal diseases such as ringworm and athlete's foot, and also methicillin-resistant Staph aureus MRSA. Within the immunology chapter, and particularly in the pediatrics consideration, there's an extensive discussion of pediatric atopic dermatitis because eczema is so common in kids and causes a great deal of suffering. I also checked both of the advanced physical assessment books that are part of the Springer 3Ps package, and each of them have very excellent and extensive coverage of skin disorders and inspection and study of the skin. So I really felt that I did not want to duplicate something that was done in great depth in either physical assessment or in later clinical course books. But I think the general principles of skin disorders can be found in infectious disease and also in immunology.
Ready for the next one?
Yes.
Okay, have a few more here. How many credit hours is this course designed for?
This would generally be, in my opinion, pathophysiology should always be a 4-credit course. I know that in many institutions it is a 3-credit course, but I would say 3 to 4 credits. I think the ideal is to have it be covered in 2 semesters, but in my experience, that hasn't been all that common across nurse practitioner programs. Now, you could teach it concurrently with pharmacology, and in that way, maybe it would be part of a shared course and be spread over more than 1 semester, and I think that would really, really benefit students. But I'm not sure how many programs do that. So I would say as a standalone, it would be a 3 to 4 credit 1 semester course.
Thank you. Here's the next question. Do you have any tips for approaching this content to a multidisciplinary student audience, one with nurses, physician assistants, MPH students, et cetera?
Yeah, I think that having the principles being the central teaching strategy really makes it an excellent fit across many disciplines. Now, I think the physician assistant curriculum, as I said, my understanding is that sometimes that has more of an integrated approach across patho, pharm, but I think that if it's a standalone course, that it would be just as relevant for any of those other groups. I think that if you have MPH students, what we have in here is some mention and some allusions to the social determinants of health that are so critical. For example, in the infectious disease chapter, we look at global statistics on deaths due to infectious disease, and we compare that to the rates in resource-rich countries. And also in the neurobiology chapter, talking about adverse childhood experiences and the effect on later life disorders. So I think that for the MPH perspective, I think you could weave social determinants of health in as a contributing principle in pathophysiology.
Here's the next question. I teach graduate level nurse educators and clinical nurse leaders. Is this book too in-depth for these groups? These students will be teaching patho and helping others understand patho in their careers.
I think they'll really enjoy it. I think that population, clinical education, has the beautiful benefit of having people who are actually seeing the real life applications of these basic principles right away. So it's not a naive audience at all. And I think when I went back for my PhD in physiology after having been a nurse, the principle, and again, I'll go back to airway resistance, and when I learned that in the medical physiology class in the first year of my PhD program, I could just picture my patients with COPD, and I could picture them doing the pursed lip breathing and really understand the principles underlying why that is an adaptation to COPD. So it was much easier for me to learn the principle once I had the real life example of the patient right in front of me. And I think that that would be absolutely ideal for clinical nurse leaders to have. I think they will enjoy it.
Here is one for Linda Herman. Linda, are you unmuted?
Yes, thank you.
What are some of the areas or examples of age-related content specific to older adults that you thought were important to include in this text?
Thank you. I think for us, it was really important to cover inflammaging, for example, and cellular senescence and procoagulation, and how these changes in the older adult really manifest with cardiovascular disease and cerebrovascular disease. Another area was the neurodegeneration, and so those are just some examples, and really just throughout each of the systems, at the end, there's specific considerations for older adults, and really weaving in the changes that have been discussed into how an older adult will present, both with their symptoms and maybe their exam findings, as well as and how these things might shape prescribing practices for our future providers.
Thank you, Linda. We have a few more questions. What are your thoughts regarding teaching pathophysiology together rather than dividing into two separate physiology and clinical pathology courses? In our current physician assistant program, we have two separate courses, but have considered combining them.
Well, I have a favorite quote from a Joni Mitchell song, and the song is Big Yellow Taxi, and the lyric is, don't it always seem to go, you don't know what you've got till it's gone. And I keep coming back to this theme that understanding a disease process, to me, has always felt more straightforward when I have been thinking about the context of the physiological process. And so, to me, that integration is what really allows me to retain the basic underlying principles. So to learn medical physiology, maybe to use Guyton or something like that. And what it's interesting to me is that over the years, from the very first Guyton edition I ever had, which I bought many years ago, Guyton has integrated much more pathophysiology. That there is this notion that the student, especially the adult learner, is so motivated to learn the things that they will actually be using in this profession that they aspire to. And so when you can make the link to what seems like a dry physiological principle, memorize this equation, mean arterial pressure is cardiac output times resistance. And you can have them learn that, but then right away say, well, you know, where does hypertension come from? And it generally comes from, we all actually don't know the actual cause of hypertension still to this day, but we know that it's manifested more by increased resistance. And then the drugs that we give, often like ACE inhibitors and things like that, are vasodilators that reduce that resistance. So to me, the integration makes it easier to learn the underlying principle, which you can then generalize and say, oh, but then if you have hugely decreased resistance, like in shock, that's a problem too, right? Because you have hypotension and the person's going to pass out. So I think that is how I evolved my approach over the years in a way that students have generally really, go back to the polling question originally, was it a good experience? And the course evaluations that I've gotten have indicated that that has provided a good experience for the students where they felt they did optimal learning.
A couple more questions. I teach physiology, a 2-semester course, to physician assistant students. Does this book have sufficient physiological coverage of the body systems, or is the focus primarily on pathophysiology?
Well, again, it is focused on the most important concepts. It does not have the depth of the Guyton for every topic of medical physiology, for derivation of equations around creatinine clearance, and do you want to teach the clearance formula, or do you want to talk about the importance of creatinine clearance as an indicator of estimated glomerular filtration rate? And so if you have been teaching to a great extent, you may not find as much detail. You would really have to evaluate an examination copy to see whether you felt that it was equivalent.
And we have one more question. Can you please elaborate on the pediatric considerations that are included?
So the pediatric considerations are done, again, it's an organ systems book. So the chapters, you know, the heart, the circulation, and on, begin with the embryologic development and talk about the normal first, the normal infant, and what they're born with as that level of function is evolving towards childhood and towards adulthood. And then the most common disorders for that age group, and particularly, and it's not an exhaustive list, it is particularly most common, and those exemplar conditions like atopic dermatitis in the immunology chapter that are showing how hypersensitivity reactions manifest in the child who is so prone to being exposed to new skin exposures, for example, and developing this. And so certain disorders and congenital defects, for example, the cardiac defects that arise in embryologic development and congenital heart defects are a major part of heart disorders of children. And so those topics are covered, and I would really encourage you to look at the examination copy and make a comparison and think what conditions you consider to be the key and line that up with what we have provided. But it is definitely organ by organ, and it varies because there are varying rates of children get a lot of infections, and the number of congenital heart disorders, we focused on the major ones. And so it's really system by system, but we had content experts developing those topics. And so I think you would find that your peers would have had that consideration.
Okay, and it looks like that is the end of our questions. So if you want to advance to the next slide, Nancy.
Sure.
For those of you who are interested in requesting a desk copy to review for your course, you'll have the opportunity to do so when filling out the post-webinar survey. So simply answer yes to the question about requesting a copy. Alternatively, you can visit springerpub.com instructor and use the ISBN at the bottom of your screen to do so as well. We've reached the end of our webinar, and I'd like to take a moment to thank Dr. Tax for her presentation and all of you in attendance for your participation. This webinar has been recorded and will be shared with all participants in about 7 days, and it will also be posted on our website under the video section for future reference. I hope you all have a wonderful day.